Good morning. I am Dr. Richard Such, former president of the Medical Society of Virginia. Thank you all very much for joining us this morning. Welcome to MSV's webinar on telehealth and its practice in this time of the COVID-19 pandemic. The Medical Society has been doing a lot of work on telehealth with many other partners, and we had some encouraging news this morning that we should look for a favorable announcement from Anthem, perhaps today or in the very near future. So I know that everybody's very interested in this subject, and it's very important to help as we try to deliver care during these unusual times. It's my distinct pleasure to welcome our guests today. Kathy Wibberly, Director at the Mid-Atlantic Telehealth Resource Center, and Dr. Colin Banas, Vice President of Clinical Product Solutions at Dr. First. I would like to mention the following for CME purposes. No commercial support was received for this activity. There are no reported conflicts of interest for any individual in a position to control the content of this program or the speakers presenting in this program. We are recording attendance and will submit that to VCU for CME credit following the webinar. VCU will email you instructions on how to access your CME certificate at the email you registered with. An additional reminder, if you are participating by phone only, please advise MSV after by calling or emailing member services. We will then report you to VCU so that you can receive the appropriate CME. Before we start, I'd like to remind everyone that MSV and its staff has continued to work diligently to pull any and all relevant resources related to COVID-19 to our website at msv.org/COVID-19. We will post a recording of this call on that web page later today, should any of your colleagues like to listen who were unable to join us this morning. We have a large number of people on our call, and we understand there will be a number of questions. Please use the chat function on your computer. We ask that you keep your questions on the topics addressed today. If we do not get to your question, or if you have one on another topic, please email governmentaffairs@msv.org. With the logistics out of the way, let's welcome Kathy Wibberly. Kathy, as I said, is Director of the Mid-Atlantic Telehealth Resource Center. She has a 30-year public service career with experience in public health, public policy program development, grant writing, and much more. She has previously worked as the Director of the State Office of Rural Health and Primary Care Office in the VDH Office of Health Equity. Dr. Wibberly, or Kathy Wibberly, excuse me.
Yep, I am a doctor, but the PhD kind. So it's all good.
Good.
So, good morning, everyone. And we can go ahead and hit to the next slide. So obviously, in case you were hiking in the Andes or stuck in a cave for the last 3 months, this little thing called COVID-19 dropped in on all of us. And this graphic on the left, I think, really just captures what has happened, at least from my perspective. So in the blink of an eye, telehealth and healthcare have become synonymous. And basically, COVID-19 has led the digital transformation of just about all of our lives. Whether you're in education or healthcare, it doesn't matter. And so I think one of the things that this has really exacerbated or highlighted for all of us is that while telehealth has been 30+ years in the making, and for which I am personally very thankful that we had pioneers and who have really advanced this field and developed best practices and developed an evidence base, it has suddenly become a quote-unquote overnight success. And so many of the barriers or excuses for not using telehealth for the healthcare provider, for the health system, and the patient were suddenly eliminated. So next slide. So just a really quick recap of what it took, I think, to just blow this thing out of the water. I think one of the biggest things, and the thing that we had heard all the time, was reimbursement. We pretty much eliminated all the geographic and site restrictions. So no longer was telehealth limited to, rural and underserved populations. It was no longer limited to facilities. We basically said wherever the patient is, we're going to provide telehealth, and wherever the provider is, we can provide telehealth. And so that has been kind of the biggest change of all of this. But we also relaxed modalities and platform restrictions. So with being able to use whatever platform you happen to have available to provide that visit, to be able to use whatever platform the patient happens to have to be able to provide that visit has made a huge difference for everyone. But then we also saw an expansion of eligible services. We saw an expansion of eligible provider types, including FQHCs and RHCs. We saw a huge decrease in barriers related to requirements for whether the patient is new or existing, or whether there was a prior in-person visit, or whether there were frequency limitations. And then we also saw relaxing or flexibility of out-of-pocket costs and co-pays for patients. And so I think all of these things have lent themselves to suddenly people saying, we can do this, and providers saying, we can do this. And I think another set of changes were also policy related, and they were related to some relaxing on licensing and credentialing, relaxation on HIPAA restrictions, and it took 10 years to relax some of the Ryan Height things with prescribing of controlled substances, but overnight that got fixed. We saw some relaxation of Stark laws and supervision requirements and even scope of practice issues. And so I think all of these things coupled have created an environment where people who were once either bound by status quo and, I don't want to try this, have suddenly said, I'm going to do this. So that has been really phenomenal. I'm getting an echo. I don't know if anyone else is.
Yeah, I hear it too, Kathy. I think that's the electric.
All right, well, we'll see what happens. So next slide. So just a little bit about who we are and what this whole COVID-19 has had in terms of an impact on us. I am a Mid-Atlantic Telehealth Resource Center, and I'm director of it. I am physically based at the University of Virginia Center for Telehealth. But I am one of 12 regional and 2 national telehealth resource centers that have been funded by HRSA, so we're federally funded. Our services are entirely free of charge, and we are really the kind of free consultation services for people. So the next slide. What has happened is, because we are the Telehealth Resource Center, we have been kind of known as, go to them if you need help with telehealth, and we will provide that service. And so as a regional telehealth resource center, we cover a 9-state region, and Virginia being part of that. And so our website is at matrc.org, and the picture of the website shows the COVID virus. And one of the things that we have had to do very quickly is to start answering questions about COVID-19. And so on the next slide, this really shows what happened for us in those 2 months. And so on the left side of the slide, you'll see a graphic that shows all 14 telehealth resource centers. For the whole calendar year 2019, we provided 4,039 technical assistance encounters. That doesn't count all of the things that we did in terms of outreach, presentations. This is just one-on-one technical assistance. If you'll look on the right-hand side, this is just for one telehealth resource center, mine. In the 2 months when COVID began, we provided 439 technical assistance encounters, just 2 months. And so this spike was from every single provider pretty much suddenly feeling like, I need to do this, I need to figure out how, I need my questions answered regarding policy changes. And this was really a challenge because policy was literally changing sometimes every day, sometimes twice a day. And so someone would call and they would say, how do I bill and code for reimbursement for this service? And we'd give them an answer, and 3 hours later, CMS would throw down a new change or a guidance document, or a press release would go out. and we'd have to say, oh, wait, no, this has changed and that's guidance changed. And this happened pretty much regularly for about a 2-week period. So it was quite the challenge for all of us to try to keep up. But we were truly inundated. And so next slide. We pretty much reached our capacity. We could not, we were literally working 60, 70 hours a week and not able to keep up and having a backlog of questions and emails and phone calls. And so we had to quickly pivot, and as all the telehealth resource centers, we had to quickly pivot to more group-based technical assistance and putting our resources online. So one of the things that we have developed and that is available to all of you right now is this toolkit. So when you click on that COVID virus icon, it takes you to this, and it's our toolkit for COVID-19, and we try to put just about every frequently asked question online, and this has helped manage our workload. But essentially, when you go out to this toolkit, you'll find sections and then subsections within sections. So everything from, how do I get started, and videos and training videos to, how do I perform a physical exam using video if I don't have peripheral devices, if the patient doesn't have peripheral devices. We have training videos on that. We have guidance documents. We've really linked to the best of the best in terms of resources. We've also have been updating this at one point daily, now probably weekly, just adding new things that have been developed. We have a very nice section on resources for specialty providers and specialty settings, so long-term care settings, working with palliative care, telehospice, all of those things are now available online. And so I invite you all to take advantage of that. Next slide. So as a result of COVID-19, one of the things that has happened is that we did get through CARES Act, a set of kind of one-time funds. So every single TRC got a nice influx of one-time funds that started this past month and will go through March of next year. And so a couple things that we have in the works are, one, we're developing a series of toolkits and trainings and best practices and lessons learned, both from our experience at University of Virginia, as well as trying to gather experiences and best practices throughout the region. And so we are going to definitely tap MSB and your members in terms of, what have you learned from COVID-19? What have you learned from rapid deployment of telehealth? What are some things that we want to keep in mind and keep at the forefront and build into a toolkit so that the next time we have, a resurgence of this virus or any virus, we can draw on that and really build on what we've already learned. We are also developing a set of website enhancements and going to test out the use of some chatbots and AIs in the background, just so that we can better and more quickly get people to the information they need. So probably in the next couple months, you'll be seeing some changes with that. But all of the telehealth resource centers have decided to work on some collaborative projects. So one of the things that we have done or will be doing is developing a video library and case studies for FQHCs and RHCs. So for those providers who are working in those settings, I'm really wanting to focus on some of those challenges and issues. But we're also reinvigorating what we had, which was a mapping tool for all providers to show where providers were using telehealth, what types of telehealth services. This is really more for policymakers as opposed to for consumers, to be able to quickly take a look at the landscape of Virginia and rural Virginia and even urban Virginia and see, where is, let's say, ENT available, where can we get mobile mammography, where can we get, tele-OBGYN services, and then also be able to, as a tool, look at least at the policy landscape, what happens when things revert back, and not that they'll ever revert back, I think, to normal, but if Medicare were to go back to, you can only get reimbursed if you are located in a particular type of facility in a particular geographic area, you would be able to click on the map and see what things are eligible, what areas are eligible for reimbursement. You'd be able to see the alignment of federal policies and resources. So if you're eligible for certain grants, if you're eligible for, let's say, the FCC or USAC Rural Healthcare Program, you'd be able to click on any point on the map and pull up all that information very quickly. And that's really helpful when you're thinking and making decisions about, let's say, opening a new practice site or partnering with a new practice site to know what you're eligible for. So that's in the works, and between now and next March, you'll be seeing some of those things available. So in the next slide, just to give you an overview of some of the other resources that we have had all along, and not as a result of COVID-19. Our resource center has been based on a series of things. So one is we have a network of consultative service partners from throughout Virginia as well as our region who have expertise in everything from things like Project Echo and asynchronous e-consults to telepsychiatry and behavioral health to school-based health to technology and all of those things and beyond. And so when people contact us for technical assistance, if it's a quick, couple minute research question or something I already know the answer to, or I can find that answer for you in the next hour, it will usually be me. I will get you that answer. But if it's something where you're saying, I am trying to start a new school-based telehealth program and I'm a primary care provider and I just need someone to walk me through this whole thing from scratch, we will assign you to one of our consultative service providers who will basically be the point person to help you navigate all of those both policy and operational challenges. We also offer virtual office hours, and that's one thing that we have offered. We increased the number of them during COVID-19. We're back to our normal operations now, but twice a month we do telehealth basics and telemental health, so you can just join by video and get your questions answered as well as brainstorm ideas. So if you have a great idea and you go, my patients would really benefit if I could do this, or if I could implement remote monitoring, or if I could find some kind of technology that would do this. We have once a month one that's focused completely on telehealth technology and working with vendors. How do I ask the right questions to vendors? How do I vet a vendor? How do I select a vendor? And that could be service providers or technology vendors, all the way to all the things about telehealth basics and telemental health. So that is available free of charge to you all, and the full schedule is up on our website. Next slide. Another thing that you'll find on our website are a number of toolkits, and we have tried to build toolkits around hot topics. So obviously COVID-19 is one of those. We have a telebehavioral health center of excellence for those of you who are on the behavioral side of things. We have a remote patient monitoring toolkit. We have a tele-MAT collection of resources. We have a telegenetics toolkit, as well as a vendor selection toolkit, and then a page that's really focused on HIPAA. We will be building more as we go. We are in the final stages of putting together a school-based telehealth toolkit as well. We also offer a Breaking Barriers Through Telehealth Award each year, and we are getting ready to announce our award winners for this year. We normally announce those during our annual conference, which we had to postpone till 2021. But those of you who are on our mailing list or who have requested assistance in the past year, or who actually registered for a conference that we had to postpone, we are doing a series of virtual online conference sessions over parts of June and July, and so you'll be getting a notification about that sometime in the next week or two. And next slide. Some other resources that you may be interested in is that we have state pages. So as I mentioned, we serve 9 states in the region, Virginia being one of them. And if you click to the Virginia regional page, what we have done is put together all of our policy-related resources. So right now you'll see a lot of links. You'll see links to the policy documents, whether it's Board of Health, Board of Medicine policy documents, Medicaid policy documents, Code of Virginia policy documents, and we will link to all of those things that are pertaining to telehealth, as well as telehealth initiatives throughout Virginia that are either state funded or at least statewide. And this will give you a nice kind of quick one-stop look at what things are. And what we try to do right now is if they are policy changes or documents related to COVID-19, we have put the words COVID-19 in those documents. If it doesn't say COVID-19, that is the standard policy prior to COVID-19. And so you'll get to at least compare and contrast what was going on. And the next slide. So one of the things that we've already started getting questions about is, now that the genie is out of the bottle, what's going to happen when this pandemic is over? And so what we've been doing is actually also collecting resources around that. And so if you go to our COVID-19 Toolkit, you'll see a series of resources related to how do I prepare for after the pandemic. I've been telling people don't expect business as usual. And there are a couple of reasons for that. One is we have a tsunami of patients who have delayed care and who have truly delayed care in terms of procedural care as well as from their fears of exposure to the virus not coming in for the care that they either want or need. We are also going to have to address the patients who want to continue to delay care out of fear of exposure. And so what do we do with those patients? So how do we use telehealth to really mitigate some of this influx that we're going to be getting, as well as the influx of potential delays and people who may be exacerbating their conditions because they don't want to come in? And how are we going to use telehealth technologies to help that? And there are definitely some things that you can put into place if you have a little bit of time to prepare, as opposed to I need to start this yesterday, including things like peripheral devices that can be sent to the home. So we really need to start thinking about that. The other thing we need to really do is fix kind of sloppy telehealth. So, as people are gotten used to using, let's say, FaceTime or Skype to do telehealth, how do we then help providers to pivot back to using HIPAA compliant platforms, and how do we really teach kind of some of the best practices in terms of etiquette and documentation and things that might have gotten a little bit sloppy in the implementation and may or may not have gotten that kind of training that people would need to do best practices. So we definitely want to get those fixes in place. Now that providers and patients have gotten a taste of telehealth, will we be able to go back to our pre-existing policies and pre-existing practices, and should we? And we're already hearing throughout the state that providers are saying, hey, I'm really seeing the use for this, or I'm really seeing that how this could enhance the services that I provide. I'm seeing this now as a tool, and I definitely want to keep some of this in place, even going back to my inpatient practice. And so how are we going to navigate the policy issues if we go back to kind of business as usual? And how are we going to create a data set to demonstrate that policy issues should be, or some of these barriers should be lifted or should be changed? And so one of the things that we have put together on our toolkit in terms of post-pandemic are a series of kind of COVID-19 measures that would be great if people started collecting, so that we can really make a policy case for some of these changes and maintaining some of these changes going forward. So that's kind of my little spiel as to who we are and what we've seen as a result of COVID-19. The next slide just gives my contact information, and I am more than happy to work with any of you all who might have some questions or want to start thinking about post-pandemic and how you prepare your practice to build telehealth in for the long haul. All right, well, thank you very much.
Thank you, Dr. Wibberly. I think you sell yourself short when you say little spiel. I'm very impressed with all that the Mid-Atlantic Telehealth Resource Center has been doing, I'm sure before, but particularly in response to the COVID pandemic. So thank you very much for sharing a very, very interesting and comprehensive explanation of a lot of the things that you all have been doing. And I'm sure that some people will have some questions for you. As a reminder, if you would like to ask a question, please use the chat function, and we will try to address those questions to our speakers when we get to towards the end of the presentation. So our next speaker who is with us today is Dr. Colin Banas. Dr. Banas has been a physician in the Richmond area since he completed his residency at VCU School of Medicine. He is currently, as I said earlier, with Dr. First, and you see it, I think, there on the slide. Before that, he was the Chief Medical Information Officer for the VCU Health System. So, Dr. Banas, thank you for being with us today.
Thanks, guys, and thank you, Kathy. That is a heck of a resource, and some of that content overlaps with mine, which will allow me to go a little quicker. So, as mentioned, I am an internal medicine doc. I am a lifetime Virginian. I was born in Leesburg, undergrad at UVA, med school at EVMS, and then residency at VCU, where I stayed for almost 20 years before jumping to Dr. First to help lead strategy and innovation. So it feels like the only section of the state I haven't quite covered is over towards Roanoke and Blacksburg, but you know, I'm a Wahoo. So next slide. So, you know, very quickly, what I'm going to go through is what I like to call rip from the headlines, where I've been accumulating headlines related to health and specifically health IT since the COVID crisis kicked off. I'll go through a really quick general COVID timeline, talk about the financial impact that we've seen to date, breeze through some of the telehealth changes, especially focusing on the recent trends, some of the lessons learned, and especially reminding everyone that there are things that we can get paid for that previously we couldn't, which is what Kathy was touching on. I have some predictions of my own, and then just a tiny bit about my company and our care communication and telehealth solution that we call Backline. Next slide. So for those of you who are on Twitter, I highly recommend following Dr. Topple, cardiologist, brilliant mind, tons of insight every day. And I think in school and residency, we got used to seeing these types of graphics about leading causes of death. And this was pretty sobering that in April, COVID was the #1 cause of death above all others, approaching 60,000 in the month of April. And he does give a nod to the social distancing and the self-quarantine that we did, recognizing that it saved at least another 20,000 lives. But heck of a graphic and a heck of a plug for Dr. Topple. Next slide. So here's my COVID timeline. You know, it doesn't feel like it. Time seems to flow very strangely now, but this all started in December. That was the onset in Wuhan. In January, I sort of skipped that month because we're all recovering from the holidays. But in February, it starts to get a hint that there's something there, and actually the market takes its first real deflection. But for me and for most of us, the whole thing got very real in March. For one of the things that sticks out in my mind was the canceling of conferences. So HIMSS is a huge health IT conference that most of us in my industry attend every year. And they made the very bold decision at the time to cancel the entire conference, which was slated to be in early March. 40,000 healthcare providers all getting together, you know, in retrospect makes a ton of sense. It probably would have been disastrous if it was still held. But right after that, South by Southwest got canceled. Everything's shifting to virtual. Within a week, a pandemic was declared. That same week, a national emergency for the United States was declared. Big for me, sports were canceled. So March Madness fell off the calendar, which is upsetting, but it does mean that the UVA Wahoos are the defending champions yet again in basketball upcoming season. So a little bit of humor there. And then telehealth really started to have its moment. In April, stimuluses were being passed and really started to focus on the financial impact of just what was going on. And we also, towards the end of the month, started to see the divisiveness with protests in places like Michigan about the quarantine and the stay at home. And in the month of May, which is now coming to a close, again, doesn't feel feels like time is flowing very strangely, but we're really focused on the shift to reopening. But as Kathy mentioned, this is not to be confused with getting back to normal. If anything, we really need to be realistic about what the new normal will be in the immediate future. Next slide. So the financial impact is pretty devastating for healthcare. So at best, hospitals were operating at a margin under 2%, and that's been obliterated in this last quarter. Of course, we know revenues are down as elective surgeries, outpatient procedures have been deferred, and beds have been emptied in preparation for this influx of COVID patients that for some areas never came, and for other areas was overwhelming. A slight contributor to this also for hospitals, expenses went up as they tried to procure PPE and ramp up testing efforts. On the outpatient side, visits declined almost 2/3, 60%. And of course, that professional fee revenue from procedures and elective surgeries dried up as all elective care was postponed. So not just procedures and surgeries, but think about anything that was even potentially elective or health maintenance related. And if you were a physician who was getting reimbursed based on RVUs or productivity measures, you were getting particularly clobbered. Next slide. So operating room minutes down 61% in April compared to April 1 year ago. Discharges down 30%, ED visits down 43%. And this led a lot of us to say, where are all the patients? Great article in the Journal of American College of Cardiology, where ST elevation, MI activation of the, the code red team or the alpha team, those are down in this country over 40%. So where are these people infarcting? Where are they? Think about all the other care that's being deferred, strokes, transplants, cancer screenings, cancer care, as people are really afraid to go to the hospital to see healthcare. And you get anecdotal stories of when these people do present, when these patients do present, they present in pretty bad shape. I've heard stories of ruptured papillary muscles from MI, and that's, to some of us, that's stuff that we only read about, and it's real now. Again, average physician practice revenue down 55%, and there's that 60% volume metric that I listed earlier. So it's bad. Next slide. So these are headlines within the last week that I have pulled out. Some hospitals prepared for coronavirus cases that never came in the Wall Street Journal. Again, a nod to that emptying beds out and preparing for surge capacity that sometimes never came, depending on where you are. Academic health systems like University of Washington furloughing 1,500 people this week. Hospital margins down almost 300%. Mass General, part of Partners, which is the 10th largest health system in the country, is reporting a $1.6 billion loss this quarter. And even Centera, in our own backyard, announced cutting exec pay and physician pay cuts in order to achieve a goal of a 10% reduction in cost. And of course, big expenditures, hospital deals, mergers, all have been either indefinitely delayed or even called off. Next slide. So, and Kathy did a great job of this. And if anything, I think Kathy's second or third slide had a very similar version of this graphic, which just tickles me too. So Kathy, we are kindred spirits, but in just 10 weeks, we were able to do more for digital transformation because of COVID than we were in the last 10 years, in my opinion. And it really speaks to that adage of don't let a good crisis go to waste. But in summarizing some of the telehealth changes, a nice reminder that there are FCC dollars dedicated and available for the adoption of telehealth. Even if you had already adopted, you can go back and get some of these dollars, or if you're contemplating adoption, you can apply for these dollars. Kathy touched on licensing changes, increased responsibilities and abilities for APPs or pharmacists, which is really, really a welcome change. And depending on where you are, the ability to practice across state lines. My wife, for example, sees ad hoc patients on a platform, and a lot of those patients are in New York because of their capacity. Kathy touched on Medicare reimbursement getting improved and expanded all the way up to inpatient rates, and the payers following closely behind. And we like to talk about HIPAA penalties being relaxed. So HIPAA didn't go anywhere, just the enforcement of penalties got temporarily relaxed, which allowed FaceTime and Skype and other consumer-facing platforms to be used, which I would advise against, but I understand in a crisis, you got to do what you got to do. Next slide. So depending on where you are, this is amazing. You know, some of the big systems have reported a 2,000% increase in telehealth visits. Over 3/4 of our hospitals are connecting with their patients remotely, and up to 50% of our physicians are using telemedicine, which is up from 18% just 2 years ago. That also tells me that there's still half of us who haven't quite adopted, and the time is now, in my opinion, because telehealth has really become what I'm going to refer to as table stakes for patient engagement and attraction going forward. So what do we know about the telehealth statistics thus far? The majority, only by a slim margin, have been women aged 30 to 40 with at least one comorbidity. And so really it is showing that telehealth is not just for the sniffles and for pink eye anymore, that it has started to establish its place in the care paradigm. Next slide. Some of the things that stayed the same, even though we've adopted this new technology. The documentation requirements are still there, much to our chagrin. If anything, you need to remember to have specific attestation statements, and I'm sure a lot of you have added your dot phrases or your auto text to make sure that these attestation statements about patient consent are being included in your telehealth visits. We still need to build meaningful relationships with our patients. We need to do it in a virtual way, and so this notion of website manner and etiquette related to telehealth visits is taking off, and I guarantee there are resources on Kathy's sites specific to this. There are still patients who don't have internet access, and so we need to be cognizant of that, and that actually led to one of the expansions in early May where telephone visits got increased approval, if you will, for use in this modality. And then of course patients are still frustrated with visits, whether it's in person or with technology. There's still a certain amount of frustration, and with telehealth it usually relates to ability to connect. So there's another headline that I ripped in my travels: surge in patients who overwhelms telehealth services amid the coronavirus pandemic. So it's not all rainbows. There are still problems to be worked through. Next slide. So, and this I really won't go too much into, but the next couple slides does focus on making sure that everyone knows the rules of the game to get paid. So a telehealth visit is the one that requires the interaction with audio and video, with real-time communication. And they are getting reimbursed equivalent to face-to-face. You do have the ability to waive co-pays and deductibles. And initially this was intended for established patients, but the HHS has announced that it will not audit if you are using this for new patients. And this goes all the way retroactive to early March. Next slide. Some of us didn't know or don't know about the virtual check-in, where a patient reaches out, asks specific questions, verbally consents to getting the care in this manner, and there's that verbal consent again. And the provider can respond asynchronously with the portal, with the text, with a phone call. And there's certain time limitations as to how often you can do this, or if a real visit is happened in the next or previous 24 hours. But again, there is something that you can bill for that you might have been doing all along as part of good care and not realizing you could generate some amount of revenue. There's also the ability to bill for store and forward communication, where a patient may send you a photo or a video, ask you your opinion, and again, asynchronously, you are giving medical advice or opinion. Next slide. Similar to the virtual check-in is the EVisit, where you can do these back and forths with the patient, again, asynchronous, for up to 7 days. And depending on how much time you document spent, the E&M level goes up in the increments displayed there. Also, as mentioned by Kathy and by myself earlier, additional specialties got expanded ability to use this and to bill for this. So think of PT and OT and speech and psychology being able to participate and bill for e-visits done over telehealth. There's also a little bit of money to be potentially generated for setting up patients with remote monitoring and things like self-monitoring of blood pressure. Next slide. Oh, and this was one of my favorites. There's actually the ability to do interprofessional consultations. So we, as a hospitalist in my days at VCU, we used to call this the curbside, which would drive the consultants crazy. But when you just need their opinion and you want them to look at the case, you don't necessarily want that full consult. There is ability for both of you to document and bill for this this curbside, if you will, which I previously did not know about, which I find very interesting. And again, there's that notion, patient must verbally consent and you must document in the medical records. Next slide. So care after COVID, Kathy did a great job of touching on this as well. Next slide. The tsunami of patients that are coming. I found this interesting. This is a look at the application in China that citizens are using to gain access to restaurants, to subways. The QR code and then the color displayed allows you entrance or denial depending on your COVID status and app tracing. So pretty interesting, and it's a little big brother if you ask me, but that is what our friends across seas are doing with technology, is related to getting back to the new normal. Next slide. So again, my predictions post-COVID, from the reading I've been doing, volumes will bounce back, but it will be erratic. It will be the new normal, and we need to prepare for this this surge in volume, if you will, and make sure that you have the right tools and the right capacity to do this. I've heard a lot of health systems planning for weekend hours and streamlining the way they're doing intake, if you will, and perhaps there's a role for technology in that. I do believe drug manufacturing, PPE, the stockpile notion for this nation will become less foreign dependent. In fact, there's a Virginia company named Flow that just won a big federal contract to assist with stateside vaccine development. I do think small practices will face big decisions. It already felt a little bit like the 90s all over again with acquisitions. In fact, there was a 70% increase in hospital systems acquiring practices within the last 2 years already. And now you layer in this financial dilemma. You can see that there might be a large number of practices that might decide maybe it's time to hang it up and retire, or do I need to be folded into a larger health system. Also, there's the pressures that were already in existence from the Walgreens and the Walmarts developing their own clinic presence, if you will. I do think we are on the verge of another crisis in the form of mental health and provider burnout. Again, go back to Twitter and you can see really impactful images of what we're calling the N95 mask scarring. So the folks with bruises because they're wearing N95 masks. I think it's taking a toll on all of our healthcare providers and frontline. And also, we know Dr. First has prescribing data from some of the things that we do. We know that mental health prescriptions in the form of anti-anxiety meds and antidepressant agents are going up within the last 3 months. Anti-anxiety meds almost up 40% prescriptions. And of course, I do think telehealth is here to stay. I think we're going to drop that the notion of tele and just call it healthcare. And I think consumerism finally gets the kick that it needed, so that we're going to see much more technology in the form of AI, chatbots, remote monitoring. I do hope that the expanded roles for our pharmacists, for our APPs, for the entire care team will persist. We've been talking about that for quite some time. And I do think that lab testing and diagnostics needs to change to that Uber-like model, to maybe a gig economy. And there actually was a company, they've sort of pivoted now, but there was a company in Virginia named Igbo that tried to take a stab at connecting phlebotomy to patients and sort of coming to them at their own convenience. And I do think that that will have a resurgence. So those are my predictions. Next slide. So clinical communication has become, in my opinion, the new normal, and telehealth, there's my term again, it's table stakes for patient engagement. And synchronous and asynchronous communication is important now more than ever. Next slide. So in my opinion, if you have not adopted telehealth, or perhaps are contemplating an additional telehealth engine, or what would I be looking for in a telehealth solution, I would remind everyone that HIPAA still matters, that the relaxation of penalties is temporary, that secure and encrypted back and forth with healthcare providers is important. So I'm not one to trust it to FaceTime and Skype, etc. I would look for something that's rapid implementation, especially if you don't have something already. I like the notion of clinician-driven telehealth. I would want to see my own patients and not perhaps that ad hoc model that I described earlier. I would want it to be quick and easy for patients, no app, no lengthy registration to get up and started. I would look for someone with unlimited usage and competitive pricing. I do not want to get charged by the number of minutes I'm using, or have a fee for each visit that I've conducted. Of course, you need to be able to defend against for your reimbursement purposes. So I need an audit trail, reporting capabilities. And honestly, I would be looking for something that's more than just video conferencing. I'm looking for that entire care collaboration suite, secure communication. Next slide. So there's a couple animations here. You can just power through them and get it to hold still. But Backline is what my company, Dr. First, has developed. Device agnostic, uses laptop, iOS, Android devices, can connect to patients without them having an app, using secure SMS and a secure micro link to a URL. Go ahead and hit the arrow or the next slide, because it'll pop in some. There we go. And obviously, it is more than just telehealth. There is, click it 2 more times. There is secure communication. So you secure texting, not just for people within your own clinic or hospital, but actually can still do these secure communication outside your 4 walls. We have the ability to do alerts if patients has been admitted or hits the ER. Document sharing, so back and forth, sending securely documents and forms to be filled out, and even the ability to do signatures for consent forms and things like that. And also to layer in a very robust medication history. Next slide. So I won't read these, but there are some pretty substantial success stories that we've had with our platform. So the Maryland Medical Society, MedChi, endorses Backline, and you can see the quote from Gene Ransom there, really wanting to promote this technology solution set across all of Maryland and across all of the country. We also have dialysis use cases. Next slide. Use cases in behavioral health, and even an entire town using it for their EMS and secure communication to their hospitals, between EMS and hospitals, and EMS to patients. So really, it is a robust solution, and again, it is more than just telehealth. it is an entire care collaboration platform that I'm particularly proud of. And I believe that takes us to the next slide. I think that'll take us to questions, and left about 9 minutes for interaction. So a bit of a whirlwind, but I hope that was helpful. Trip down 3 months of memory lane, and a solution that I'm particularly proud of. So with that, I'll turn it back over.
Thank you very much, Dr. Banas, for a very interesting presentation and actually a lot of practical information about how to implement telehealth and get reimbursed. As a reminder, this webinar and the slides will be posted following our time together this morning on the MSV website at msv.org/COVID-19. So that if you want to go back and look at some of this, or you have colleagues who would like to see some of this, it will be available for them. And also a reminder that we have some questions coming in, but we would welcome more on the chat function. Okay, so we're going to test out doing a poll today for the first time on one of these webinars. So look for that and respond if you see it pop up. We want to get an idea of how many people are using telehealth. So we have some questions that have come in. The first one is a very specific question, and I'll address that to Dr. Banas. You mentioned FCC dollars. Dr. Weiss says, what are FCC dollars and how do we apply? Can you give a little more detail about that?
Yeah, sure. Well, there's the echo. You can email me directly, but and I guarantee that Kathy's site also has a reference to this. But the Federal Communication Commission actually has grant dollars set aside for the promotion and adoption of telehealth, and there are 2 forms to fill out and submit. And I mean, it's literally that simple if you qualify. But if you don't find it with a quick search, you honestly reach out to me. I have all the materials as well.
Yeah, we do have that information. If you go to our homepage, there's an announcement on funding opportunities, and if you click on that, it'll give you information about grants available as well as the FCC funding opportunity.
Okay, thank you. So Dr. Weiss, both of our speakers are pointing you in the direction of getting more information on that. We had a question that came in from Dr. Venuto Ashton. If you are practicing medicine using telehealth in 2 states, for example, Virginia and North Carolina, do you have to register as a business in both states?
Holy cow.
You don't have to register as a business, but you do have to be licensed in both states.
That's my understanding as well, and there are provisions for expedited licensure in adjacent states during this pandemic. Okay, let me see. We had a couple of other questions here. Someone asks, please comment on doing Medicare wellness visits via telehealth.
My understanding is that you can. Yeah, go ahead, Kathy.
Yeah. Medicare definitely allows it and will reimburse for it. And if you do go to our toolkit and go into best practices, there's a section on conducting a physical exam, and there is a whole document on how you would actually do a wellness check using telehealth.
Okay, great. There was a question here, let me find it, asking, do you have any updates regarding extension of end dates for telemedicine appointment reimbursement being equivalent to in-person visits? And the person specifically talks about Anthem ending 6/17 for now, and despite their webinar yesterday, they haven't clarified whether the reimbursement will continue at the current rates. As I said at the beginning, we are anticipating a favorable announcement probably within the next week from Anthem, and the Medical Society has certainly been in dialogue, as we always are, with the payers, including Anthem. But do our speakers have any further information about that? whether the reimbursement will continue and how long.
I mean, it would be speculative. Go ahead, Kathy.
Oh, yeah, I do not have additional information. We hear rumors, even from CMS, that some things will continue well beyond even when the state of emergency has ended.
So sort of along the same lines, what long-term changes to telehealth would you like to see from the insurance side?
Oh, sorry. You know, as long as the momentum keeps carrying us forward, I am pleased. This was something that we were trying to do in my former role as a CMIO that was very hard to get traction. So the fact that we were able to make something positive out of this crisis is refreshing to me. I mentioned in my presentation that I would like to see the expanded roles for pharmacists and other members of the care team, and allowing them to bill and generate revenue. To me, that is a huge deal. You know, as Joint Commission and other regulatory agencies always talked about the care team, if you will, but a lot of times the stuff still came down to, well, the doctor has to do this, the doctor has to document that, and it seems sort of contrary to the notion of all of us on a team working together for a common goal. So to me, that would be my biggest wish, expanded roles.
Yeah, I think the thing that I would like to see continue, and I think most people would like to see continue, is reimbursement for that direct-to-consumer, getting rid of the geographic or facility restrictions and basically providing telehealth and getting reimbursed for it wherever the patient may be. I mean, that truly is kind of care anywhere and everywhere model. I think the other piece that has been really well received is the interprofessional consultation that is being reimbursed somewhat through Medicare at the moment, but even across Medicaid and private payers, it would be really nice to see that. I think we have seen and heard a lot of really good stories. I know that we just did a webinar at UVA on inpatient e-consults and being able to essentially save PPE and save exposure for providers by being able to bring in a specialist to an infected patient's room virtually, as opposed to in person, and being able to do that curbside consult using the EMR.
Okay, thank you. Maybe one final question. We're almost out of time. We know that access to broadband is often a hurdle in certain areas to many things, including expanding telehealth. What do you think the state can do for older, rural, and low-income populations that maybe don't have the access?
Well, first of all, it was that expansion into allowing telephone visits to count. So at least we have something to be a little bit inclusive of these areas. There is definitely legislation that's been trying to promote access in these areas. I also wonder if some of the improvements in things like 5G or wireless might make a difference in the near future. But Kathy may know even more than me in this particular realm.
Yeah, I think Virginia has had I know the governor has had a big initiative in trying to push broadband out. Oftentimes it's that last mile connection that's difficult. Most practices and businesses have connection, but it's to the home that has been the challenge. And so that, you know, the incentives to get cell towers built and fiber activated in some of these rural areas is an economic, I think, question and a challenge for the telecommunications companies.
All right, well, thank you to everyone who joined us today, and particularly to our speakers, Dr. Wibberly and Dr. Banas. We have completed our poll. We didn't have everyone respond, but of those who responded to the question, have you used telehealth during COVID-19? We had 59% saying yes, and 41% saying no. So that's sort of in line with what Dr. Banas said earlier, in the ballpark of 50% of physicians are using it at this time. So once again, thank you very much for joining us, and the webinar will be posted on the website for those who were unable to view it this morning.
Thank you.
Thank you.
Thank you.